begin with, I think first try and understand why does a involutional entropion or ectropion occur. So our lower lid, basically it is suspended by two horizontal forces and one vertical force. And when we talk of horizontal forces, it is the medial palpebral ligament, and on the other side there is the lateral palpebral ligament. And inferiorly, if you see, there's a vertical component, that is the tarsus, the lower border. We have the inferior lid retractors, and also it is basically the tarsal thickening which is important, which is serving as a skeleton for the lower lid. So as the age advances, what happens is there is a basically thinning of the tarsus, and the preorbicularis and the preseptal orbicularis, the preseptal and the pretarsal orbicularis, they tend to move over each other. So when will it happen? Whenever your vertical forces are at fault. So whenever you decide what surgery has to be done, preoperative assessment of the structure at fault is most important. Now look at these pictures. If you look at the upper lid, she has an involutional component. What is happening? दूर करूँ? Pass करूँ? अच्छा. But you can see the lower lid is inturned, whereas the same thing is happening in the picture below, but the lower lid is outturned. So what we have to see is whether there is a generalized lid laxity, or it is combined with a medial canthal laxity and a lateral canthal laxity, or if there is an inferior lid retractor weakness. So how do we check it? You just pinch the lower lid, and if you are able to pinch it away about 6 to 8 millimeter, then that means your distraction test is positive. If you are able to pull this lateral canthus about 2 millimeter away, the punctum is pushed 2 millimeter away, that means there is a medial canthal laxity. In these patients, if you try and only address the generalized lid laxity, you may not have a very good post-operative result. So other thing that you have to see is whether there is a inferior lid retractor dehiscence. So what do? You tell the patient to look down. Normally what happens is about 1 to 2 millimeter, the lower lid moves down when you look down. But if that is not happening, that means there is an inferior lid retractor laxity. Lots of times, as a rule, I have seen lot of our residents, they just jump on to doing a Jones procedure, that is a inferior lid retractor plication in all entropion, involutional entropion cases, and end up with failures. So if you have a combined generalized lid laxity or medial canthal that is not addressed, simply doing a Jones procedure is not going to help. Now how do you grade it? Suppose you have an ectropion, you have to grade it so that you know what procedure you have to choose and how much you expect that the correction will be there. So when the puncta is not opposed to the globe on looking up, it's mild. When it is not opposed to the globe, even in the primary gaze, it's moderate. And if it is not opposed, even and the fornix is also exposed, then it is a severe ectropion. Now I'll just show you a couple of videos. So you can see this patient. This patient had a generalized involutional, generalized lid laxity with involutional entropion. So the procedure of choice in this case was a modified Wheeler. So what you do is you mark 4 millimeter from the lid margin, and then you expose the orbicularis muscle in front of the tarsus. So this is the orbicularis belt which has been exposed, and you do a triangle. The tarsus is cut with a base down triangle. Remember, when you're correcting an entropion, the triangle has to be base down because you want to shorten the lower part of the tarsus, not the upper part. Whereas when you're correcting the ectropion, it is reverse. So you take out this triangle, suture the ends of the tarsus back, and then you do a double breasting of the orbicularis. And on table itself, you get a very good correction. This is the simplest procedure and can be easily done with very reproducible results. Immediately post-operatively, there may not be a very good contour on the first day, but eventually it takes its place and it gives a very good result. Now remember that tarsal strip procedure is a procedure which is used extensively both for entropion and ectropion. Now how does it differ whether you're using it for entropion or ectropion? One part. The other thing is, do we do tarsal strip procedure in isolation, or do we combine it with other procedure? So if your medial canthal tendon is not very lax, then you can simply do a lateral tarsal strip procedure both for ectropion and entropion. The difference is here, if you see these sutures, in entropion, these sutures, this is the cut end of the tarsus, these sutures are passing just from the upper and the lower border of the tarsus. Whereas when you are correcting the entropion, what you are doing, एक मिनट आप वो कर दीजिए, टाइम वो कर दीजिए. So when you are correcting the entropion, what you want to do is that you should have basically the lower part also to be sutured. एक मिनट मेरा कर्सर छोड़ दीजिए. हाँ. So you can have this suture which is passing from the lower border also. So this gives a correction for the entropion. So just to see the video now. So this patient has an ectropion. So what we do is we do a lateral cantholysis first, and then we expose the lateral border of the tarsus. And once a strip of this tarsus is exposed, then you just pull it up laterally. And remember, this tarsus has to be inserted to the lateral tubercle. So this lateral tubercle is about 4 millimeter interior to the inner border of the orbital margin laterally. So you should not just insert it right at the margin. And this is the excess of the skin is then excised. So again, if you have to correct the entropion, you remember the suture placement which I have shown in the figure below. Now, what is the advantage over the full thickness slit resection is that if you do a full thickness slit resection, there were problems related to notching, and also there was loss of granular secretions, whereas in lateral tarsus strip procedure, the problems that have been documented is that since the tarsus is being inserted directly to the orbital margin, there have been formation of granulomas related to the meibomian glands. Now, another procedure, that is the subdhijang suture, that was described by Dr. Malik et al., and we later on studied it further using a 5-0 proline suture to suspend the, I'll just show you a video later, suspend the lower lid in involutional ectropion, and I'll show you the video together. And this can be combined with various procedures, that is the medial conjunctivoplasty, where you just have to correct the medial ectropion. So you can combine the two procedures. And this is a small click where both the scar below is not actually the cause of ectropion. This is a horizontal incision which is given at the lateral tarsus, lateral canthal, and from here you pass the needle, straight needle, which has this is the proline suture, which is first tied onto the lateral canthus, and then a straight needle is passed from the lateral canthus to the medial canthus. This proline suture is also anchored to the adjacent periosteum, otherwise it tends to slip away. And remember, it has to be buried very well, because all proline sutures, they have a memory and they tend to cause extrusion at a later date, so it has to be buried well. And this is a curvilinear, like a DCR incision that you place. You expose the medial canthal tendon, and then this is combined with the medial conjunctivoplasty, where a tarsoconjunctival strip is removed, and you can see this is a 4 by 8 millimeter rhomboid kind of incision which is made. And after exposing, the sutures are passed from both the lips, and it is brought out to the skin and tied on to a bolster. So this is the medial conjunctivoplasty, and it immediately interns your punctum. Now this is the needle which I was saying, a straight needle is passed from the lateral end to the medial end. It is brought out and it is tied onto the medial canthal tendon here, and then it is buried in layers. So this is combination of the two techniques. So whenever you have such a problem, you may combine 2 or 3 procedures to give a perfect result. So this is then tied, and what is most important is that it has to be sutured in layers, otherwise there is a chance of suture exposure. Now we studied this is a polypropylene sling, that is the 5-0 proline with combined transconjunctival retractor plication and tarsus strip procedure, and we found equally good results with both the procedures. Only thing was, there was some cases where the proline got exposed, and for that we had to intervene later. Now this is another technique which we have recently started doing. This is a silicone sling which we use routinely for our ptosis surgery. I tried using it instead of the proline because proline was having exposure related problems. So we started using this, and this was passed from medial to the lateral canthal angle similar to what we were using the fiberproline. So this is the silicone sling. The only problem with silicone sling is that since it has a chance of extrusion, so you have to be very careful in burying it. And this needle which is there, it is not as pliable as I was using the other needle. So passing it becomes a little difficult, especially if a patient has a very long nose, prominent nose. But otherwise, in patients where it is done well, it is giving good results. And especially, I would not recommend it for mild ectropion, but for patients like paralytic ectropion, especially post-facial palsy, this is another procedure which can be tried other than, of course, doing tarsorrhaphies, which we usually do, lateral tarsorrhaphy and medial canthopexies that we do. So this gives a very good, adequately good correction post-operatively. Another thing that you have to be careful is not to pass it. It has to be in the correct plane. It has to be close to the lid margin in the pre-tarsal plane. So just to conclude, a preoperative assessment of the structure at fault is important, and the procedure has to be chosen accordingly. Mostly lateral tarsal strip procedure works in most of the cases, which may be combined with medial canthal plication or inferior lid retractor plication. Thank you so much. And of course, this is a book which will be released today. This is 20 years of hard work, and of course, contribution from a lot of co-authors like Dr. Grover, Shalu, and my residents, Shalin, Tonvi, and so many others who have helped me in bringing out of this book.